I'm Dr. Sandra Laura Kramers, one of the eye surgeons here at Visionary Ophthalmology, and I want to quickly go through how to decide when to have cataract surgery and also what kind of implant and what kind of surgery you should have. So basically a cataract is a change in the clear lens protein of the lens. The lens is located behind the iris, which is located behind the clear part of the cornea, the front of the eye. When with aging or trauma or diabetes, smoking, genetics, the lens protein can get cloudy and form different types of cataracts. There's a nuclear cataract, a cortical cataract, a posterior capsular cataract, and each one of these cataracts can determine its effect on your vision. What we do is we dilate the eye and we can take a look under the microscope to see what kind of cataract you have. If the vision is worse than 20/40 in the distance, in a dark room, or even with glare, which is called the glare test, then we recommend cataract surgery, and most insurances cover the surgery because it's affecting your vision. There are some patients that have clear lens exchange, where even though they don't have a cataract, we do remove the lens to put an implant that allows patients to try to be glasses free. And those are for patients that are going to pay out of pocket because the insurance won't cover that. Once you are told you have a cataract, then the question is when. And it depends on your activities of daily living, how much it's bothering you. I tell patients that if you were a truck driver that depended on nighttime driving, you'd want the cataract surgery done as soon as possible. Most patients have a few months to decide on that. The next issue is deciding on what kind of cataract surgery to have. Years ago, nobody had a choice. Everyone had standard phacoemulsification and a standard monofocal implant, which is just a plain piece of either silicone or acrylic that basically is in the eye, in the capsular bag, and that was their only choice. Now they have to choose between laser cataract surgery and standard phacoemulsification. Standard phacoemulsification is covered 100% by the insurance. Laser is not. The laser is called a femtosecond laser, which helps us decrease the overall energy, the ultrasound energy of phacoemulsification that's pumped into the eye. And when we look at a cataract, what I compare it to is a pillow inside a pillowcase. And I tell patients that the top part of the pillowcase is very important in terms of helping us center the implant. We take off the top part of the pillowcase manually if we're using the standard phacoemulsification. With the laser, it's done precisely. And it also chops up the lens proteins to be able to suck out the protein more effectively. So the laser allows us to decrease the overall energy that's pumped into the eye, and that's good for the overall health of the eye. It decreases our risk of corneal problems and macular problems. It improves the recovery time, it decreases the recovery time, and so most eye surgeons in the world would have a femtosecond laser cataract surgery if they had a choice. So that's the first decision. Second decision is the type of implant you're going to put in the eye. There's basically three categories for this. The first is called the multifocal implants. It's essentially an implant that has rings inside the implant that allow you to see on one ring the distance, another ring the intermediate, and another ring for reading. It works very well in the majority of the patients to try to be glasses free. It's not 100%, and some patients still need reading glasses, some patients still need glasses, but it's that one chance to let you have an ability to be free from your glasses. The three categories of multifocals are Techness, Restore, and Resume. Each has a different focal point. One's better for distance, one's better for intermediate, one's better for reading, and so we try to ask you questions to determine what you want for your vision. The downsides of the multifocal lens are, in some patients, there can be halos and glare that last more than a few months. Most of people's brains will accommodate to that halo and glare, but in a few it still is debilitating and needs to be addressed, and that's very rare. The second category is called the accommodating lens, which includes the crystal lens and the TrueLine. This type of implant is essentially a monofocal type of implant that moves back and forth inside the eye. The TrueLine corrects for astigmatism, and astigmatism means that the front surface of the cornea, instead of being shaped like a basketball, is shaped like a football. And astigmatism will distort your vision after cataract surgery. So our goal is to decrease as much astigmatism, if not all of it, after cataract surgery, and the TrueLine allows us to do that. The accommodating lens are for patients that have any type of macular problems. They want to be glasses free or have that chance, but they have either a epiretinal membrane or macular degeneration or macular changes, or they've had previous refractive surgery. And so those are patients that we recommend the accommodating lens. The downside of the accommodating lens is that there is some controversy as to how effective it is in the long term. Some patients, the capsular bag is like saran wrap. It'll kind of come around the implant and may restrict its movement. So just to be aware of that. The third category is called the toric lens. The toric lens corrects just for astigmatism, which basically means that you'll still need reading glasses, but you will not necessarily have to worry about astigmatism for the distance. And so you'll be usually glasses free for the distance, although no guarantees with any of these implants. So those are things I wanted to mention to you. If you have any questions, feel free to email me at drdrkramers@visionareyedoctors.com. Thank you for your time. Thank you.